So today we're going to do a quick review of the respiratory tract, and I'm going to mention a lot of the little things that you might be able to find. The way I like to do it is I like to actually show you how air comes in and out of the body. So what we need to do first is start with the nose. And so one of the things you notice with the nose is you have two holes on each side, and the holes have hair on it. And as you take a deep breath in, the air goes in, and inside you hit 3 bumps called the nasal conchae, superior, middle, and inferior. So the nasal concha, air comes in, hits the nasal concha, which are actually covered with mucus, so they're called the nasal turbinates. And when this laminar flow hits these concha, it goes turbulent. So the air starts going everywhere in the nasal cavity. Now over here, you actually do have your cribriform plate of the ethmoid bone. You have the perpendicular plate and the vomer, which is making the nasal septum. You also have the hard palate, which is made up of the palatine bone back here and the palatine process of the maxilla over here. And you have the soft palate, which is the connective tissue hanging here. We're now in the nasal cavity. And one of the things to know is if we were to take this and look at a tissue of the nasal cavity, what we would find is these long cells, and occasionally we'd have this bulgy cell, and we'd see these hair-like projections called cilia. The other thing that happens is the nuclei are kind of scattered. They're not in one line. And sometimes the cells have different shapes. So you may have one coming this way. You may have one coming this way here. Times as if there's multiple layers of nuclei. So we call it this tissue ciliated, as it looks like there might be more than one level, but there's only one. Basement membrane is here. We call it pseudo-stratified. And they're column shaped, so they're columnar epithelium. Now underneath this, we have a capillary bed. We have a bunch of capillaries here. And what's happening here is you have specialized type of cells like this one here, which is called the goblet cell. And the goblet cell secretes mucus, coats this. Now as the air is turbulent, the air hits the mucus and particles get stuck here. What ends up happening is these cilia beat the mucus back. So it goes to the back of the nasal cavity, drips down, and causes you to get that mucus in your mouth, which you'll end up swallowing. So one of the things that's happening is because of this mucus of the goblet cells, the area here is being filtered. As you have a capillary bed so close, heat is also going to be lost and goes into the nasal cavity. So the air is going to be warmed. So it's filtered, warmed. And the other thing is water is going to come out of here and humidify that. So air is being warmed, filtered, and humidified in the nasal cavity. We get the oropharynx. This area here is called your nasopharynx. You get to the area of the mouth, which is your oropharynx. Here, your hyoid bone coming up this way. Laryngeal prominence here. The larynx here. You have the coracoid here. And this air is going to go into the tube up here. This here is your esophagus, laryngeal pharynx here. Then you get into your larynx, and the tissue returns to the ciliated pseudostratified columnar epithelium. Here in the mouth, you're going to end up having stratified squamous epithelium. So we go into the thyroid cartilage, coracoid cartilage, then we go into the trachea. When we get to about the sternal angle, manubrium, you have your body here, the xiphoid process here, ribs are coming off this way, clavicle here. When you get to about the sternal angle, the trachea, which is behind here, splits. Now the trachea so far, once it gets into the thoracic cavity here, it's actually in an area called the mediastinum, which is where the heart also lies. So we have the trachea and it branches. Trachea over here branches too. And so we have 2 bronchus. Now the bronchus will end up giving secondary bronchus. And this one will have 3 secondary bronchus. This one, the left, will only have 2. As we have 3 here and 2 here, these 2 will have the same name, which is superior. These 2 down here will have the same name, which is inferior. And this one will be the middle. In the trachea, you have these signet rings, and they're connected to one another with fibrous tissue. These rings are hyaline cartilage. And then when you get to the secondary and tertiary bronchus, you have tertiary here, you lose the rings, and you end up having just plates. You also have smooth muscle throughout this entire tube. And when you get to your bronchioles, termini, you even lose the plates. And then you go into your alveoli. Your alveoli, you have it inside your lungs. Again, you have your trachea, you have a right and left. Now the reason the right angle tends to be so much more obtuse than the left is because you have the heart here. So you have the right bronchus, you have the secondary bronchus, secondary bronchus, secondary bronchus, tertiary bronchus comes off here, tertiary bronchus, and the lungs here, and you'll have one here. This right here is your oblique fissure. On the right side, you have an inferior, which comes here, this way. You have a middle, which comes here, this way. And you have your superior, which is up here. So you have superior, middle, and inferior. This area here is the base, and you have a cardiac impression on this side here. This here is a lingula, which is a little tongue, which as you don't have a middle lobe, you have that lingula in here instead. Now, just like this is called the oblique fissure, just like this is called your oblique fissure, which should be more coming this way like that. This here is called your oblique fissure as well. So these two are both oblique fissure. This one is called your horizontal fissure. And now we have the lungs and the conducting system. Now, if we were to take a piece of lung and take a look at it in a slide, what we'll see is we'll see a bunch of these flat cells called type 1 alveoli cells. And so we have alveolar sacs here, and they're attached to one another with alveolar ducts, which the bronchioles come into. So they'll have the sacs and the ducts. The bronchioles come in here. A lot of times you'll see capillaries in here. The reason is you need capillary beds around these alveolar sacs. Now these cells in here are called type 1 alveoli cells, but you also have another big globular cell here called a type 2 alveolar cell, which makes something called surfactant. And now we have mostly the tissues that make up the respiratory tract. Now the other thing we really want to talk about is the muscles. Now the main muscle of respiration is the diaphragm. So if we have a thoracic cage up here, our diaphragm is down here. Our abdomen is here. Our lungs will be in here, and we have an apex, which is this tip here, the base here, and where the blood vessels come in is called the hilum. And we have our trachea coming in here. For this to work, we need a diaphragm. We also need the alveoli and the lungs to be able to expand. So what happens is this. Our diaphragm, which is down here, contracts. When it contracts, it flattens. What that means is the thoracic cavity increases in size. Abdominal contents get pushed down. Now, there's an equation that you will see in physiology, which is P1V1 equals P2V2. What it means is, as pressure changes from here to here, the volume has to change. So if the volume changes, so does the pressure. As the volume changes here, there's more volume, so the pressure has to decrease. As the pressure decreases, air comes rushing into the trachea and goes to the alveolar sacs where gas exchange takes place. When it relaxes, elastic fibers within the alveoli and the lungs pull it back up, which cause a change in pressure again, causing the air to come back out. Well, it's not the same air, it's different molecules, which I'm going to talk about. But that's the basics. What that does is it gives you normal, quiet breathing. Where in physiology, sometimes they talk about spirometry. And a spirometry measures something called tidal volume. TV for tidal volume. And in tidal volume, it's just normal, quiet breathing. It's your diaphragm and the elastic recoil. If you take a look at your breathing, that's what normally happens. Now, if you decide to take a really deep breath, you have more available than you're using. That's referred to as your inspiratory reserve volume. And you can blow it all out. And then you can also blow out more than what you have available. This is your expiratory reserve volume. And so what happens is, when you need to use muscles of forced inspiration to use your inspiratory reserve volume, the main ones are your scalenes, which are found from your cervical to your ribs, and your sternocleidomastoid, sternum, clavicle, and the mastoid process. So these two muscles are the main ones for breathing. Pectoralis minor and the serratus anterior can also help, but mostly the muscles of forced inspiration are going to be found in the neck area. If you hold your neck and take a deep breath, you can see how those muscles bulge. Now, if you want to expire more, use your forced expiratory reserve volume. What you need to do is you need to push the diaphragm up quicker. The way you do that is with your rectus abdominis, transverse abdominis, and your external and your internal obliques. And so those are your muscles of forced inspiration. Putting the cardiovascular with this is pretty simple. So we have our right atrium, which gets blood from the body, goes to our right ventricle, which pumps blood to the pulmonary trunk. In the blood, you have carbonic acid, bicarbonate, and some carbon dioxide. This is inside this blood vessel. When it gets to the lungs, water and carbon dioxide, and that goes into your alveoli. In the alveoli, oxygen comes in. This actually leads to something really interesting. If you remember, CO2 plus H2O gives you H2CO3, which ends up becoming hydrogen. Start losing carbon dioxide and water. This equation goes the other way. If you're breathing out a lot of carbon dioxide, what you end up doing is you end up losing carbonic acid. And so if you breathe out too much carbon dioxide and water, you get rid of carbonic acid, which ends up giving you a respiratory acid, which you'll deal with that in physiology a lot. If for some reason you can't breathe out, you build up the carbon dioxide and water, and it moves to give you carbonic acid, so you have more acid. So that's your respiratory acidosis. You're building carbon dioxide and water because you can't get, and making carbonic acids because you can't get it out. In alkalosis, you breathe out too much carbon dioxide and water, so you get rid of carbonic acid. Oxygen will then go into your pulmonary veins. Pulmonary veins will go into your left atrium, to your left ventricle through your aorta, which goes through all your body that you've talked about, dropping off oxygen, picking up carbon dioxide, and then you go back to your heart. So that's pretty much the basics of the respiration. There's always a little more. If you take my lab manual, it actually tells you what you're going to need. And next time I should be talking about the digestive tract. I hope you enjoyed this, and hope it wasn't too short.